Good afternoon. Welcome back to the House Health Committee. Today is Friday, March 13th, a very lucky Friday the 13th. We are on voting list number 7. Ooh, also a lucky number. Look at that. So we're going to start today with the withdrawals. Do we have a motion on the withdrawal? All right. They've been moved and seconded. Any questions, concerns on the withdrawals? Seeing none, all in favor say aye. Aye. Anyone opposed, go ahead and raise your hand. All right. So we are going to start with House Bill 684. This is health insurance material changes to provider networks, notification and special enrollment period. This is Lisa, and we welcome back Madam Vice Chair, and we're putting you to a lot of work today.
This departmental bill expands the requirements on carriers regarding notification to enrollees about the termination of providers from provider panels. The bill alters when and how carriers must notify the insurance commissioner about a material change to their provider network, including requirements relating to updating a carrier's access plan. The bill requires carriers and health systems to provide notice of intent to terminate a contract. For specified contracts, carriers and health systems must adhere to the terms of the contract for at least 90 days. The bill also requires carriers in the individual market to provide a special enrollment period for an individual whose provider is terminated from the health plan's provider panel. There are amendments on the first page of your packet. The amendments alter the requirements for notifying enrollees regarding the termination of a provider from a provider panel. They provide that specified continuity of care provisions apply to providers of behavioral health in addition to providers of primary care. They clarify that balanced billing protections apply to the continuity of care period, requires the commissioner to develop a uniform form for use by carriers, providers, and health systems for requesting continuity of care, and strikes language requiring carriers to provide enrollees with advance notice of termination of a contract with the health system. The final amendment alters the enrollment date for the beginning of the special enrollment period and the effective date for coverage obtained during the special enrollment period.
Vice Chair Collison.
Thank you, Madam Chair. Thank you, Lisa. This is truly a consumer protection bill, and it became necessary when we had a breakdown in talks between the United Healthcare and Johns Hopkins system. And so folks who were in United actually lost their providers who were affiliated with Johns Hopkins. This bill seeks to address that by making sure that the enrollees have enough notice and that there are some, make sure that there's interaction between the carriers and the hospitals in a responsible way. So this vote in subcommittee was, the amendments were unanimous, as was the bill as amended. I move the amendments, please.
All right, amendments have been moved and seconded. Is there further discussion on the amendments? Delegate Shalega.
If I heard you correctly, is this the United Healthcare fix? Are we fixing that problem, or is this?
As much as we can. Which is really just about, because we can't interfere in their negotiations.
Right.
But we can tell them, you got to make sure that people know what's happening. And also, if you do this, then you have to make sure that there's continuity of care and that you can't count that as out of network after that period. You have 90 days after the termination of the contract to make sure that it is still considered in network.
Thank you.
Mm-hmm.
Any further discussion on the amendments? Seeing none, all in favor say aye. Aye. Anyone opposed, go ahead and raise your hand. On the bill as amended. It's been moved and seconded. Is there any further discussion on the bill as amended? Seeing none, all in favor say aye. Aye. Anyone opposed, go ahead and raise your hand. That bill passes unanimously. Who does not want to be on this bill?
It's a departmental bill.
Oh, it's a departmental. Oh, you are correct. We all want to be on this bill. Right. Dang it. Okay. We will all be on it in spirit. House Bill 746. This is Maryland Medical Assistance Program and Health Insurance Collaborative Care Model Cost Sharing Prohibition. This is Lisa and Vice Chair Cullis.
As amended, this bill requires the Maryland Department of Health to provide coverage for services provided in accordance with the collaborative care model. The amendments are on page 3 of your packet, and the amendment number 1 is technical. Amendment number 2 strikes language that would have prohibited commercial carriers from imposing a cost sharing on coverage for services provided in accordance with the collaborative care model. Requires certain commercial carriers to provide coverage for services provided in accordance with the collaborative care model, and requires the Maryland Healthcare Commission to conduct a study on the impact of prohibiting cost sharing as proposed under the original bill.
Vice Chair Cullison.
So we have seen, and there's lots of evidence around the value of the collaborative care model when the primary care doc and the behavioral health professionals are coordinating. And what we're looking at this bill is a compromise in order to make sure that this is recognized by making sure that it is mandated coverage to begin with. So while a lot of carriers were already covering it, not all of them were. This bill assures that they will all cover it at their regular co-insurance rate. And then we will study what the financial impact to premiums will be if there were no cost share. So that's what the bill does, and it was unanimous in subcommittee, so I move the amendments.
All right, amendments have been moved and seconded. Is there any other further discussion on the amendments? Seeing none, all in favor say aye. Aye. Anyone opposed, go ahead and raise your hand. On the bill as amended. All right, it's been moved and seconded. Is there further discussion on the bill as amended? Delegate Szeliga.
Thank you. I'm reading the league testimony, and it says, you know, they suggest a study. I heard you say study in the amendments. Are you putting in a mandate and a study? And if so, why not do the study first?
We have a study that relates to the cost share now, but we don't have a study that's related to what the impact of the cost share would be, removing that would be. And so that's what the study does. It's because when MHCC studies something, they look at utilization and what's being paid out of premiums and at all the different plans and programs. And that's how they determine what the effect of per member per month is. But what they don't consider is the cost share element. So either your copay or your coinsurance. That's a new sort of modeling of studying. So that's what we're asking them to do. Within that model, what would happen if we completely eliminated the cost share? When we do the mandate, it's at no cost share normally. In this bill, it's not at no cost share normally. It's that they will cover it. They'll cover the collaborative care.
And so do you know what the fiscal note is?
It doesn't have a fiscal note.
Because they're already doing it?
You're right, for the
Okay.
most part.
So
right.
it's not really a mandate, it's something they're already doing?
It's maybe codifying what they're already doing.
Okay.
Okay. And then we're interested in what will happen, or what would happen if we eliminated the cost share. And that's what we'll find out in a year.
Okay, and just to clarify, this is only for the fully insured, regulated 841,000 people
Yes.
who already have 52 mandates. But this is not a mandate. It's because is anyone not doing it?
One or two of the smaller companies are not doing it. So this would require them to do it. So it would have an impact on them.
So it does have a cost.
For those companies, not to the state. There's no cost to the state.
Has a cost to people.
In those companies, yeah, and
Could you potentially then say this is going to eliminate choice in healthcare, because the smaller companies who are not doing this may be able to offer a lower premium. And now that you're making them do this, their premiums will go up.
that's Right, that's not, yeah, that's not what the league was saying to us. The league was saying that they thought this was all doable within, and they represent small and large companies.
Okay. I don't know how it can't raise that, but, all right, they said unfavorable. So the league said unfavorable.
Due to the original bill. The original
Okay.
bill removed all of the, it mandated that there would be no cost sharing in the collaborative care model. They opposed that bill. This bill was a compromise with them.
Okay. Thank you.
Okay?
Delegate Kaufman, followed by Delegate Riley.
Yes, I just want to make sure I understand, because I actually loved the no cost sharing provision of the bill. I liked it better as it came in. So I just want to make sure I heard you correctly, that that was a necessary change to achieve consensus, which we like to do. Is that fair?
Yeah, I think it's fair to say it was a compromise. I wouldn't tell you that the carriers love this, but they can live with it, and they are very interested in what the study will show.
Okay, so it was to make it palatable. All right, I'm just trying to understand. Thank you.
Palatable is a great word.
Thank you very
Delegate.
much.
Thank you.
Would you like me to share my conversations with, around this?
Sure.
Around this compromise? Just to give a little context, when we got the study back, which identified a potential savings to ratepayers based on the fact that they would get more upstream, the concern was that, to what the vice chair said, that it did not reflect the collaborative care as it is now in the private market. Because right now, although most insurers provide it, they don't provide it the same way. So by having it required, it actually creates more continuity. So when we study what the financial impact would be on the premiums, we would actually we would be able to be studying sort of apples to apples comparisons. So it just has to be something that they offer, but in order to have accurate information on what it would cost to eliminate the cost sharing, and for them to sort of figure out the actuaries, which I'm so grateful the Vice Chair understands much better than I. They felt that this was a reasonable compromise to give us the information that we would actually need to do the study to determine whether or not it would adversely impact premiums. So I hope that's a little clarifying. So let me go to Delegate Riley.
Sure. So that conversation and what you're saying happened after the bill hearing? Okay, because during the bill hearing, I remember, asking the question if the collaborative copay would be more expensive, and their answer was yes. And it was around, the carriers were saying it was probably be about 20% left for them to pay on the copay. So how does that add up, that, there wouldn't be a cost?
Well,
So
right
is-
now, under the bill as amended, that's all maintained.
Okay.
It doesn't go away. So that is not going to have, for this year, it's not going to have any
Right.
impact at all.
So you're trying to find out with this bill now if it's going to be 20% lower or higher?
Thank you, Delegate.
Thank you
Yes.
very much.
Is there any further discussion? We are on the bill as amended. Okay, just making sure. So it's been moved and seconded. All in favor say aye. Aye. Anyone opposed, go ahead and raise your hand. Who does not want to be on this bill? All right, Delegate Shalega, Delegate Morgan, Delegate Kipke, Delegate Hutchinson, Delegate Riley. All right, thank you very much, everyone. House Bill 931. This is healthcare facilities, nursing homes, medical director requirements. This is Lisa and Lopez.
This bill requires a physician designated to serve as medical director of a nursing home to meet specified requirements and obtain a specified certification on or before a specified date. The Maryland Department of Health may grant a physician a time-limited extension for obtaining a medical director certification on a showing of good cause. The bill removes the requirement that the secretary, in consultation with stakeholders, establish qualifications for a nursing home medical director or anyone acting in their absence, and instead requires MDH to adopt specified regulations. There are amendments that start on page 5, and these amendments, Amendment 1 is technical, Amendment number 2 strikes a provision that would have prohibited a physician from being a designated medical director at more than 2 licensed nursing homes. And the third amendment moves from September 30th, 2028 to September 30th, 2030, the date by which designated medical directors are required to obtain certification, and replaces the requirement that the Department of Health maintain a directory of medical directors with a requirement that nursing homes post specified information related to medical directors on the nursing home's website.
Delegate Lopez.
Thank you, Madam Chair. This bill, the amendments moved without any friction, and so did the bill as amended. I would love to move the amendments.
All right, amendments have been moved and seconded. Is there any further discussion on the amendments? Seeing none, all in favor say aye. Aye. Anyone opposed? Go ahead and raise your hand. On the bill as amended. All right, it's been moved and seconded. Is there any further discussion on the bill as amended? Seeing none, all in favor say aye. Aye. Anyone opposed, go ahead and raise your hand. And this is favorable with amendments, passes unanimously. Who does not want to be on this bill? I'm not even going to say it. All right, so everyone will be on this bill, including Delegate Hill, the bill sponsor. All right, House Bill 1087. This is healthcare facilities, surgical smoke evacuation systems. This is Lindsay and Gazzoni.
This bill requires each healthcare facility that performs surgical procedures to adopt and implement policies by January 1st, 2028 that require the use of a smoke evacuation system during a surgical procedure that may generate surgical smoke. There are no amendments.
Delegate Gazzoni.
This was very straightforward in subcommittee, passed unanimously. Absolutely, please move the bill.
All right, it's been moved and seconded. Is there any further discussion on this bill? Oh, Delegate Shalega.
Notice that the Hospital Association said they already do this. So just kind of wondering, I know in my professional life, we did JAGO hospital healthcare facility work and maintenance work and things on the Joint Commission's requirements for hospitals. So is this already part of JAGO? And if the hospitals say they are doing it, why do we need it?
Delegate Gazzoni.
My recollection from the hearing was that while they may be saying they're doing it, it's not happening in all instances, and that there, in particular, may be some doctors in specific who aren't interested in doing this. And so this is to help the nurses that are in there and other hospital employees not be exposed to all the smoke.
And would you say this also gives them a little bit of authority?
Leverage, yes.
In making the ask in
Yes.
what could be an uncomfortable situation if it's not turned on?
And it covers more than just hospitals. It covers
And my colleague is reminding me that it also covers ambulatory surgeries. So it's a little bit broader than just the hospitals.
Okay. Was that the only opposition, and did they come to the subcommittee and oppose, or was it just a letter they put in?
There was no discussion in the subcommittee
Okay.
about it,
Thank you.
so nobody came.
Seeing, Delegate Riley.
Yeah, if I remember that they have the ability to do it in the hospitals, but they didn't have the authority, like the nurses didn't have the authority to say, hey, doc, I want it turned on. But we never did find out why the physicians aren't currently doing it. Did we ever find out why they don't want to do it? What the conflict is? And, I mean, apparently it's just a switch of a button. But
I'm going to allow the doctor to speak on this.
Delegate Johnson and then Delegate Hill.
Thank you. I think that question actually was asked to the nurses when we did the bill presentation. And the nurses basically said that some doctors are just set in their ways and they don't like it on. And you're right, it kind of puts them in an awkward position to try to ask, because it is up to the surgeon the way the operating room runs. So, thank you, Madam Chair.
Thank you.
yeah,
Delegate Hill.
I can only speak for some surgeons, can't speak for all surgeons. So understand that the devices vary. There are some devices, as they described, that are on the tip of a cauterizing device, the electric cauterizing device. Some of them are bulky. And so when you're trying to get into tight spaces, having the smoke evacuator on the tip can make it difficult to manipulate during the surgery. They also described freestanding devices that sort of like canisters or pumps that sit off the operating table that you don't handle, that just filter it, the HEPA filters out of the room. Not every facility has that, not every room has it, okay? So typically, because the surgeons and the people, it's not just the circulating nurses, but the OR techs who are right there, the surgeons, surgical assistants, everyone is subject to it. So typically, if they don't want to use it, it's because it's interfering, the particular device that's available is interfering with the surgery itself. And sometimes if they don't have the device, you literally have someone with the vacuum that's used to suction up fluid, standing there with the vacuum, holding it near the smoke to suck it out. So there are lots of ways to get it out. And in any particular situation, it really is a matter of what's going to facilitate the surgery.
So under this bill, then, if we pass this bill, will the physician have the opportunity to deny the request because of the patient's safety?
I think the protocols would require that it would be used, and then the committee that determines the needs in the OR and what to purchase might have to go about making sure that if they don't have the devices that can work for particularly tight surgeries, that they end up getting them. So there are a number of ways to evacuate smoke.
All right, thank you.
Delegate Shalega.
To set the record straight, I was skimming the Hospital Association's testimony and did not read it carefully enough. They are not taking a position, so that would be why they didn't show up. Thank you.
Thank you for setting the record straight. Any further discussion on this bill? And this is a favorable, so we are on the bill. All in favor say aye. Aye. Anyone opposed, go ahead and raise your hand. All right, that passes unanimously. We are now on House Bill 1091. This is Health Insurance and Dental Plan Organizations, Dentists, Assignment of Benefits and Reimbursement of Non-Preferred Providers. This is Lisa Ann Cullison.
This bill expands provisions of law governing the assignment of benefits under certain health insurance policies to apply to dentists in addition to physicians, which is already authorized by current law. The bill also establishes parallel provisions governing assignment of benefits and non-preferred provider dentists for dental plan organizations. There are amendments on page 6 that make technical changes.
Vice Chair Cullison.
Thank you, Madam Chair. So this bill, what it does is allows your dentist to bill your insurance company before you pay in full. And then you'll know, once the insurance company has paid its portion, then you'll be billed for whatever's left after that. So most physicians currently do that, but dentists have not been able to do it, so this bill allows them to do it. It was unanimous both with the amendments and the bill. I move the amendments.
All right, amendments have been moved and seconded. Is there any further discussion on the amendments? Seeing none, all in favor say aye. Aye. Anyone opposed, go ahead and raise your hand. On the bill as amended. All right, it's been moved and seconded. Is there any further discussion on the bill as amended? Seeing none, all in favor say aye. Aye. Anyone opposed, go ahead and raise your hand. All right, that passes unanimously. Who does not want to be on the bill? All right, we're all on there. House Bill 1112, this is this is Health Insurance Coverage Protection Commission, Study on Individual and Group Health Insurance Market Stability. Lisa Ann Cullison.
This bill requires the Maryland Health Insurance Coverage Protection Commission to study and make recommendations for individual and group health insurance market stability. The amendments strike the requirement for an actuarial analysis and require the commission to consider whether to adopt a direct payment system or fee-for-service model for all services covered by Medicaid, And 2, to identify ways to sustain and increase premium assistance in the individual market.
Vice Chair Cullison.
Thank you, Madam Chair. So this commission was set up with some legislation in '25, and it's a robust and diverse membership, and it was set up so that we could be responsive to any changes that were done at the federal level regarding, healthcare accessibility and affordability here in Maryland. However, in discussions in the interim with other healthcare experts, we said there are still some other things that this commission could be studying in the short term, and that's what this bill does, is require that commission to consider the things that are in the bill, so that are in this current bill. So with that, I would move the amendments.
All right, amendments have been moved and seconded. Is there any discussion on the amendments? Delegate Shalega.
Do the amendments take away the $250,000 fiscal note? Okay, and finally, I don't see a charge specifically in here for the study to figure out how to reduce health insurance costs.
That's in the original charge. Reduce it with respect to all the changes that we made. Now, long-term reductions are going to fall to long-term reduction considerations are going to probably fall to the bigger long-term commission. But this one was set up to look at the short term. That make sense?
Short term in reducing health insurance costs, or give?
Our goal is always to try to reduce cost. We've seen what's going to increase our cost, at least in some instances, because of changes that have been made. So what this commission is currently doing is saying, this is the impact on our state. How can we help to minimize that increase because of what's happening at the federal level?
Is it also looking at what we're doing to insurance at the state level?
Oh, it absolutely is.
Okay,
yes.
good. So we can't blame it on the feds.
No.
Okay, thank you.
Delegate Riley.
Thank you, Madam Chair. Have we heard the bill for the long-term fix yet?
No, that's coming up.
It is
Couple
coming,
more
still
bills.
coming.
Right, still
Okay.
coming.
Do we know the bill number?
I should. I think it's 1112.
11, well, that's what this one is.
Oh, sorry, that's not this one then. 1367, thank
Okay.
you. Down at the bottom of the page. Right.
Okay, thank you.
Thank you.
And would you say, Madam Vice Chair, that this is sort of like the responsive commission, and then we have the proactive commission that's looking to the future, and this is kind of looking to respond to what's happening? All right.
I would characterize it that way. Thank you very much.
All right, thank you very much. So we are on the bill as amended. It's been moved and seconded. We've had the discussion. All in favor say aye. Aye. Anyone opposed, go ahead and raise your hand. All right, that passes unanimously. Who does not want to be on the bill? Delegate Shalega, Delegate Morgan, Delegate Kipke, Delegate Hutchinson, Delegate Riley. All right, thank you very much. We are now on House Bill 1151. This is Maryland Department of Health Study on Maryland Medical Assistance Program reimbursement of hospice room and board services. This is Lisa and Lopez.
As amended, this bill requires the Maryland Healthcare Commission and the Maryland Medical Assistance Program to study the impact of requiring Medicaid to provide reimbursement for room and board services provided by a hospice house. The study must analyze overall Medicaid savings per enrollee death associated with the use of hospice care compared to costs associated with other services provided during the enrollee's last 6 months of life. And the study must also analyze the projected fiscal impact of the provision of reimbursement for hospice house room and board services, examine how reimbursement for room and board services would affect hospital readmission rates, improve hospice length of stay, improve early access to hospice services, result in a reduction in deaths in hospitals, and result in a reduction in emergency department utilization. Finally, the study would include a comparison of other states that provide reimbursement for hospice house house, room, and board services. There are amendments on page 8 in the packet. The amendments, they require the Healthcare Commission and Medicaid to conduct the study rather than the Division of Healthcare Financing and Medicaid. And they alter, clarify, and add to the study requirements as just described.
Delegate Lopez.
Thank you, Madam Chair. The subcommittee discussion on this was without drama, amendments passed with no opposition, but there was one vote in opposition of the bill because it is a study. And so I move the bill, or move the amendments, excuse me.
All right, amendments have been moved and seconded. Is there any further discussion on the amendments? Delegate Lopez? Oh, okay. So all in favor say aye. Aye. Anyone opposed, go ahead and raise your hand. To the amendments. We're just on the amendments. Do I have a motion on the bill as amended? No. All right, it's been moved and seconded. Do we have discussion on the bill as amended? Seeing none, all in, Delegate Chalega.
What's the final fiscal note? There isn't a fiscal note, or?
The fiscal note was $26,000 in fiscal year 2027.
So the fiscal note didn't change?
Not that I'm aware of. I don't know if the sponsor has any additional information.
Thank you.
You're welcome. Any further discussion on the bill as amended? Seeing none, all in favor say aye. Aye. Anyone opposed, go ahead and raise your hand. Delegate Chalega, Delegate Morgan. All right, thank you very much. That is, we are now on House Bill 1280. So this is supporting our caregiver infrastructure program feasibility study. This is Lisa and Lopez.
Do you want to ask if anybody wants to postpone?
Oh, yes, I'm so sorry, thank you. Before we do that, Bill, who does not want to be on House Bill 1151?
So no Morgan and Schlegel and everybody else is on.
I just want to make sure everyone heard that question. We're going back to House Bill 1151. Who does not want to be on the bill? Delegate Chalega, Delegate Morgan, Delegate Riley. All right. Thank you. And thank you, Lisa, for the reminder. House Bill 1280, excuse me. Now we're going to supporting our caregiver infrastructure program feasibility study, Lisa and Lopez.
As amended, this bill requires the University of Maryland College Park, with assistance from the Department of Human Services, to study and make recommendations on the feasibility of establishing and operating a supporting our caregiver infrastructure program to provide universal monthly payments to a caregiver for each dependent for whom a caregiver provides care. The study must examine the economic impact on the state and local economies, including potential increased labor force participation, enhanced tax revenues, potential decreased participation in public benefits programs in the state, and the overall economic vitality of the state. There's amendments on page 10. They require the University of Maryland College Park rather than the Office of the Comptroller to conduct the study. They do require the University of Maryland College Park to consult with the Comptroller on specified items of the study, and they extend the reporting and termination dates by a year.
Delegate Lopez.
Thank you, Madam Chair. Amendments passed unanimously. There was a discussion about whether the University of Maryland was willing and ready, prepared, met the qualifications of being able to do the study. They wrote a letter saying that all those things were true. The bill passed with one vote in opposition because it is a study. And I move the bill, or move the amendments, excuse me.
All right, amendments have been moved and seconded. Is there discussion on the amendments? Delegate Kipke.
Thank you, Madam Chair. I'm just looking at the Department of Aging's written testimony, and they're saying that there are 2 unfunded caregiver grant programs already in existence as a result of past legislation. Both of those funds have never had funding since their establishment. So I'm just curious if what is this bill achieving when it appears that work has already been done in this area, but just the money hasn't funded any grants?
Delegate Lopez.
Yeah, I think this, from my understanding, the focus of the study is a bit more nuanced than the work that had been previously done. So it aims to fill in the gap specifically about how, various ways to support caregivers. From my understanding, the other work group studies commissions that were doing this group didn't have the same focus.
Okay, thank you.
So we are on the amendments. Seeing no further discussion on the amendments, all in favor say aye. Aye. Anyone opposed, go ahead and raise your hand. Delegate Kipke.
That's the amendment?
This is on the amendment. Oh, okay. So the amendments passed unanimously on the bill as amended. All right, it's been moved and seconded. Any further discussion on the bill as amended? Seeing none, all in favor say aye. Aye. Anyone opposed, go ahead and raise your hand. Delegate Shalega, Delegate Morgan, Delegate Kipke, Delegate Hutchinson, Delegate Riley. Who does not want to be on this bill? Delegate Shalega, Delegate Morgan, Delegate Kipke, Delegate Hutchinson, Delegate Riley. All right, thank you very much. And I just want to make sure that everybody was on the same page. House Bill 1365. This is Health Occupations Insurance Menopause Provider Training and Coverage Requirements. This is Lisa and Cullison.
This bill requires certain carriers to provide coverage for the evaluation and management of menopause and menopause-associated symptoms. The bill also requires the Maryland Department of Health to identify at least one training program on the evaluation and management of menopause and menopause-associated symptoms that may be completed to satisfy continuing education requirements for specified health occupations licensees and certificate holders. The health occupations boards are allowed to adopt regulations establishing the maximum number of continuing education credits that may be granted. The amendments are on page 11 of your packet. They alter the membership of the State Advisory Council on Health and Wellness by adding the executive director of the Maryland Commission for Women and one expert on menopause. They clarify that the treating healthcare provider will determine the evaluation and management of menopause and menopause-associated symptoms for purposes of insurance coverage, requires the Maryland Department of Health to establish an action plan with community health workers to provide access to menopause-related health care services, and requires MDH to evaluate methods to increase opportunities for clinical training on menopause.
Vice Chair Cullison.
Thank you, Madam Chair. So yesterday I had a little extra time on my hands because I couldn't be here, and I learned that this is a national problem. And I suspect that whatever generation succeeded the boomer generation, of which I am a member, they must be reaching that point in their lives where this is becoming more and more of a concern. So this bill is really trying to address something that actually, I had a conversation with a physician recently who said, we are really struggling with how to identify the symptoms of that are related specifically to menopause and find the right treatments for them. So this bill is trying to build the foundation for making sure we have everything in place to support folks who are going through it at the right time. So with that, the amendments were unanimous, and after much discussion, the bill was unanimous as amended. So I move the amendments.
All right, amendments have been moved and seconded. Is there any further discussion on the amendments? Delegate Shaleg.
What did the amendments do to get unanimous support since it has a mandate in it?
As I recall the conversation, it was personal relationships with those who are experiencing these symptoms.
There's also the insurance.
Yeah.
Right, right, and the insurance, the carriers were in line,
Okay.
supportive is too strong, but not neutral, I guess is what I would
Is
say.
this the one where the insurer said they thought this could potentially have long-term savings?
Yes.
Okay, thank you.
Thank you. So we are on the amendments, and I will tell you that I can tell you what generation was raising their hand. So we've moved the amendments, moved and seconded, had the discussion. All in favor, say aye. Aye. Anyone opposed, go ahead and raise your hand. On the bill as amended. It's been moved and seconded. Is there any further discussion on the bill as amended? Seeing none, all in favor say aye. Aye. Anyone opposed, go ahead and raise your hand. All right, the bill passes unanimously. Who does not want to be on this bill? Delegate Shalega? All right. All right, thank you very much. We're going to House Bill 1367. And this is Commission on Reimagining Healthcare in Maryland. This is Lisa and Cullison.
This bill establishes a commission on reimagining healthcare to envision a comprehensive healthcare system for the state. The commission must study numerous issues and make recommendations regarding the establishment of a new healthcare system. The report, there are several reports that are due, a preliminary report by December 1st, 2027, and December 1st, 2028, and a final report by December 1st, 2029. The Department of Health will provide staff for the commission, and the bill is contingent on MDH determining funding levels needed to conduct the work of the commission and securing private funding to do so. There is an amendment in your packet that alters the preamble to include a reference to dental, vision, and hearing, and the amendment also adds to the membership of the commission a representative with expertise in the practice of advanced practice clinicians.
Vice Chair Cullison.
Thank you, Madam Chair. So as I sort of mentioned earlier, there were a group of us meeting during the intersession to talk about the issues that we discuss in this committee every single year, and the concerns and barriers that face our current healthcare system. We know from experience with the Kirwan Commission, or the Blueprint for Excellence Commission, which took a high-level view of all of the aspects of the educational system and made recommendations to improve it. You may or may not agree with the recommendations of the commission, but it was designed to improve our system to make sure that it delivered better outcomes for students. That is the same purpose as this commission, to take a high-level look at all of the issues that are facing us in Maryland around healthcare. You know, the fact that we spend a lot of money on healthcare and we don't have the same outcomes as other places that are spending less money. We have economic barriers to prescriptions and just medical debt. We have incredible shortages of providers. We have disparities in healthcare integration. And we have lots of issues around reimbursements for practitioners. So we need to look at this in a holistic way. This is what our chair just referred to as the proactive commission. And as Lisa indicated, it is contingent upon getting some foundational funding in order to accomplish this work. So the amendments were unanimous, but the bill was not. I think there were 2 in opposition to the bill as amended. I would move the amendments, though.
All right, amendments have been moved and seconded. Is there discussion on the amendments? Seeing none, all in favor say aye. Aye. Anyone opposed, go ahead and raise your hand. On the bill as amended. All right, it's been moved and seconded. Is there discussion on the bill as amended? Seeing none, all in favor say aye. Aye. Anyone opposed, go ahead and raise your hand. Delegate Shalega, Delegate Morgan, Delegate Kipke, Delegate Hutchinson, Delegate Riley. Who does not want to be on this bill? Delegate Shalega, Delegate Morgan, Delegate Kipke, Delegate Hutchinson, Delegate Riley. Thank you, everyone. We are now on House Bill 1377. This is Prescription Drug Repository Program Redirecting Safe Prescription Drugs Pilot Program. This is Lisa and Johnson.
This bill establishes a Redirecting Safe Prescription Drugs pilot program to expand the existing state prescription drug repository program by including medications collected during the Federal Drug Enforcement Administration's National Prescription Drug Take-Back Days. To administer the pilot program, the Secretary of Health must collaborate with DEA and 4 drop-off sites in the state registered to participate in the Take-Back Day. Each repository must coordinate with DEA to separate eligible, non-controlled, unopened prescription medications collected by the drop-off site on the take-back day and redirect them to a repository program, ensure that collected prescription medications are packaged in a manner consistent with the requirements of the state prescription drug repository program, ensure that controlled substances are provided to DEA, and transfer eligible prescription medications to a repository. The bill also establishes reporting requirements. There are amendments on page 18 that correct terminology throughout the bill and change the termination date.
Delegate Johnson.
Thank you, Madam Chair. There was no discussion on the bill, and the bill passed unanimous. I'd like to move the bill with amendment.
All right, bill has been moved the amendments. Do we have a second on the amendments? All right, amendments have been moved and seconded. Is there any further discussion on the amendments? Seeing none, all in favor, say aye. Aye. Anyone opposed, go ahead and raise your hand. All right, on the bill as amended. All right, it's been moved and seconded. Is there any further discussion on the bill as amended? Seeing none, all in favor, say aye. Aye. Anyone opposed, go ahead and raise your hand. All right, it passes unanimously. Who does not want to be on this bill? All right. House Bill 1470, Medical Assistance Programs, Drug Dispensing, Cost of Dispensing Survey and Fee-for-Service Professional Dispensing Fee. This is Lisa and Johnson.
This bill requires the Maryland Department of Health, beginning in 2026, to conduct the in-state cost of dispensing survey at least once every 3 years. Within 6 months of completing the survey, MDH must adopt regulations establishing a fee-for-service professional dispensing fee based on the results of the survey. There are no amendments.
Delegate Johnson.
Thank you, Madam Chair. There was no discussion in subcommittee. However, the vote was 5-2. There were 2 delegates that wanted to take a look at the fiscal note.
Move the bill.
All right, it's been moved and seconded. Is there discussion on the bill? Seeing none, all in favor say aye. Aye. Anyone opposed, go ahead and raise your hand. All right, the bill passes unanimously. There are no amendments. So we are going to House Bill 1523. This is Alcohol, Tobacco, and Cannabis Commission Unauthorized Consumable Products Enforcement and Seizure. This is Chris and Hill.
This bill authorizes the Field Enforcement Division of the Alcohol, Tobacco, and Cannabis Commission, ATCC, to issue a citation or other charging document to a person who has committed a violation of Title 21, Subtitles 2D, 2E, and 2F of the Health General Article, which are restrictions on tianeptine, kratom, and phenibut. It authorizes the Executive Director of ATCC to seize, confiscate, or destroy an unauthorized consumable product that is offered, advertised, or displayed for sale to a consumer in the state as specified. It authorizes the district court to impose additional sanctions. The bill prohibits a retailer from distributing, selling, exposing for sale, or advertising for sale an unauthorized consumable product and imposes criminal and civil penalties on violators of specified provisions. The bill also expands the prohibitions against retailers advertising kratom and phenibut products to minors and requires MDH to notify ATCC of changes in the regulatory status of unauthorized consumable products, including kratom, tianeptine, and phenibut. The bill takes effect July 1st, 2026. There were amendments, which is in the triangle packet, the Delta packet that we discussed yesterday. Amendment number 1 makes technical changes. Amendment number 2 removes kratom and phenibut from the new ban while leaving current restrictions intact. It revises the defense for violations of those restrictions, and it makes technical changes.
Delegate Hill.
Yes, so we're picking up from the conversation we had yesterday. If you recall, Delegate Ross, the bill's sponsor, had received, and I've been copied on, some additional requests that essentially amounted to wordsmithing. And we're satisfied with the amendments that are in the Delta package, and I'd like to move those amendments.
All right, amendments have been moved and seconded. Any further discussion on the amendments? Oh, Delegate Kipke.
Thank you, Madam Chair. I just want to make sure we address the concern I raised in the hearing. If someone owns a business, buys a product to sell, and the product is labeled in a legal manner, I want to make sure that they are not exposed for, civil penalties or whatever it is when, there's no way for them to set up a lab and identify what's in there.
Madam, thank you. So there was language that talked about there being a legal defense if they're relying on the label presentation of a distributor, manufacturer, and so forth. We narrowed that down, made it a rebuttable defense if they're relying on the label of the manufacturer. So.
Good, thank you.
Thank you.
Thank you for the question. I'll just add that we made the determination, since we had already reviewed, our council had already reviewed the amendments as discussed yesterday, and because judiciary is actually second on this bill, that it was more appropriate to move the bill as we had amended it and considered it. So with that, we are on the amendments. We've had the discussion. All in favor of the amendment, say aye. Aye. Anyone opposed, go ahead and raise your hand. All right, do we have a motion on the bill as amended? All right, it's been moved and seconded. Is there any further discussion on the bill as amended? Seeing none, all in favor say aye. Aye. Anyone opposed, go ahead and raise your hand. Who does not want to be on this bill? All right, it passes unanimously, and we're all on it. All right, House Bill 1563. This is Emergency Room Services and Post-Acute Care Coverage and Facility Studies. This is Lindsay and Gazzoni.
As originally introduced, this bill would have prohibited certain policies and contracts issued by an insurer, nonprofit health service plan, or health maintenance organization from denying a covered emergency room service solely on the basis that the insured or enrollee did not experience an emergency medical condition. The bill requires the insurance commissioner to include specified data on post-acute services in the annual summary report on carrier appeals and grievances. By January 1st, 2027, MHCC, in conjunction with HSCRC, must conduct 2 studies. The first to quantify bed capacity in hospitals and post-acute settings and recommend a collection and auditing process for bed reporting, and the second to analyze options to facilitate clinically appropriate transitions from acute to post-acute care settings. There are amendments beginning on page 19 in your packet, which strike provisions prohibiting denial of covered emergency room services and instead authorizes the insurance commissioner to conduct an examination of a carrier that has issued a pattern of adverse decisions or grievance decisions for a claim or authorization request for services in or related to services in an emergency department, authorizes the commissioner to have an adverse decision or grievance decision independently reviewed, and adds a requirement that the MHCC studies be conducted in consultation with representatives from the post-acute care industry.
Delegate Gazzoni.
Yes, again, this passed through subcommittee. I'm not positive we even had any questions. It's very straightforward. Yes, please.
All right, amendments have been moved and seconded. Is there any discussion on the amendments? Delegate Shalega.
So there was a lot of unfavorable testimony. Did these amendments take care of that? So now everybody's on board. I mean, it was pretty equal, 50-50. And how about the mandate? Is there a mandate? Is there a fiscal note on it now?
You can correct me, but we believe we could change the fiscal notice significantly.
There we go. Yes, the fiscal note was because of the requirement that the emergency room services be covered, and that's removed from the bill.
So now there's no fiscal note.
I assume there is no fiscal note, because
Okay.
that was the only thing listed as a cost in the bill.
And the opposition to the bill has been satisfied through the amendments?
Yes.
Thank you.
All right, seeing no further discussion, we are on the bill as amended, correct? Make sure I'm right. Keep me honest. All right, all in favor say aye. Aye. Anyone opposed, go ahead and raise your hand. Who does not want to be on the bill? Delegate Shalega, Delegate Morgan, Delegate Riley. All right, thank you very much, everyone. This does conclude our voting session. Can you let me know when we're down?